Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with previous lecture series, today we'll be dealing with localization of spinal cord lesions, that is we call spinal cord syndromes, how you locate them. This will be very helpful to all the students of 4th year for oral exam as well as theory exam, and you will see lot number of cases with spinal cord involvement in your everyday practice. So we are going to talk regarding localization of spinal cord syndromes, or we call spinal cord lesions. We know very well the central nervous system, that is brain and brainstem, is connected to the body via spinal cord. In spinal cord we have got ascending tracts, descending tracts. We have got gray matter, white matter. So it is a portion which is connecting peripheral nervous system to central nervous system. And once you understand this, it will be very easy to locate the spinal cord different disorders, or we call spinal cord lesions or spinal cord syndromes. For that, first you have to understand the cut section of spinal cord. So whenever you take a cut section of spinal cord, it is having two sulcus. That is, if we look here, this will be what we call as the anterior, and this will be posterior, which will divide the spinal cord into two halves, right and left. We have got gray matter, that is posterior horn, anterior horn, and we have got a lateral horn. And this is called posterior column or dorsal column. This will be lateral column, and this will be the anterior column, and this is called anterior commissure. So these are the different portions. This is white matter, this is also white matter, this portion is also white matter, and the central small hole we call central canal. So now if this is an enlarged portion, we can see that this is a posterior column. Now in that posterior column, the medialmost fiber is tractus gracilis or fascicle gracilis, and that contains sacral fiber and fiber from lower limb, while cuneatus contains fiber from abdomen, thorax, chest and upper limb. So this will be the position. So this becomes very important depending upon the lesions, which part will be first damaged, which part will be spared, etc. This is a spinocerebellar tracts, dorsal spinocerebellar, ventral spinocerebellar, and this particular is lateral spinothalamic tract, and in that also you can see that outermost fiber is sacral fiber, then you have got a lower limb fiber, then you have got a thoracic, chest and upper limb. As far as the lateral corticospinal tract is concerned, again outermost fibers are sacral fibers, then lower limb, then thorax, chest, and then you will have upper limb. This particular is a composition of those tracts. If we understand, if we remember this, it becomes very easy. Say, giving a simple example. If this is a central canal lesion, or we call as intramedullary lesion, which starts from central canal like syringomyelia. So it will first compress the structure which is very close to the central sulcus. So the structure which is very close to the central sulcus is what we call as the lateral spinothalamic fibers, which are crossing in front of the central canal. So those tracts will be first to be damaged. And then you have got a fiber which are concerned with bladder. So you will get involvement of even bladder as lesion expands. Now if this medullary lesion expands further, Now, as far as the corticospinal tract is concerned, sacral fiber will be spared. Sacral and lower fiber will be spared. First thing to get damaged will be the chest fiber. Then that is upper limb and chest. And then you will have a thoracic involvement, etc. Same thing will be there in case of a lateral spinothalamic tract. So if there is a lesion from extramedullary area, then first fiber to be affected will be sacral fiber as far as corticospinal tract is concerned. So lower limb and sacral will be first to be affected, while you will have upper limb spared. Same thing will be happening as far as the lateral spinothalamic tract. So you will have an involvement of the sacral fiber, lower limb fiber, then you will have thoracic, chest, and then upper limb. So upper limb and chest will be spared. First to be involved will be sacral and lower limb. So this type of presentation will help you to identify whether it is intramedullary or extramedullary, etc. So this becomes very important, and we will have a lot of different types of syndromes. We call it the posterior spinal cord syndrome, anterior spinal cord syndrome. Then we have got a central canal syndrome, hemisection, complete transection. All those different types of damages which takes place in the spinal cord, will be talking about that. So now we are talking about relation of a spinal cord to vertebra. So if we get an injury at C4 level of vertebra, at that level C5 spinal cord comes. So we will have a quadriplegia, or we call tetraplegia. So all four limbs will be involved. If we come down to C6, again the chance of tetraplegia will be always there. If the lesion is below T6, then upper limb is spared. As upper limb is spared, now lower limb will be involved, will get paraplegia. So up to lumbar 1, we'll have paraplegia. Now as far as the spinal cord segment is concerned, spinal cord will end at the level of T12L1. So if we get the damage in the lower part of the thoracic vertebra, we'll have a paraplegia. If we get the damage above C5 vertebra, we'll have a quadriplegia. And if we get the damage between T1 to T12 vertebra, we'll have paraplegia. So this will be important as far as damage to spinal cord is concerned. Then we'll be taking separate segments and what will be the different types of presentation. Now here if we mention dorsal column is concerned with fine touch, vibration and proprioceptive sensation. And we have already mentioned that tractus gracilis is medialmost fiber which is carrying sacral and lower limb, while cuneatus is carrying thorax, chest and upper limb. So this will be the distribution. While lateral spinothalamic tract is concerned with pain and temperature, and anterior spinothalamic tract is concerned with crude touch and pressure. So this will be the presentation as far as ascending tracts is concerned. And we have already mentioned that in a corticospinal tract, the outermost fiber will be sacral fiber, innermost fiber will be chest and upper limb. So if you correlate with the vertebral level, upper cervical, they are at same level. At C5 level, we have to add 1. So at C5, C6 spinal cord segment will be there. In upper thoracic, you will have to add 2. That is at T3, you will have T5 segment. And middle thoracic, you will have to add 3. So at T7, you will have a T10 segment of spinal cord. And in the lower part of the thoracic vertebra, you will have to add right from 3 to 5. So roughly we say that at T10, you will have lumbar 1. And at T11, you will have a lumbar 5. So roughly you will have to add almost 5 segments. And at T12L1, you will have the terminal part of the spinal cord segment we call as a conus, and then we have got cauda equina. So that will be the thing which you will have to remember as far as the vertebral level is concerned. So this will be correlated with the vertebral levels. So depending upon the damage at the vertebral level, we can find out what spinal cord segment can be affected. Now as far as the spinal root is concerned, spinal root, we have got an anterior spinal nerve root and we have got a posterior spinal nerve root. Those two combines to become the spinal nerves. In cervical segment, the same number of spinal root or spinal nerve will come out between. So C2 spinal nerve root will exit above C2 and C1 will exit between cervical 1 vertebra and skull. C8 root will now exit below C7 vertebra, that is between C7 and T1. And then we know that all subsequent spinal root will be exiting below the same number of vertebral bodies. But spinal cord will end at the level of T12L1. So after L1, you will have a cauda equina. And at T12L1, we will have a conus medullaris. This will be as far as the spinal cord is concerned, and this is as far as spinal nerves is concerned. So we have already said that upper cervical, same. Lower cervical, add 1. Upper thoracic, add 2. Lower thoracic, add right from 2 to 3. That is in almost we say that the mid thoracic level, that is C7 to T10. And lower thoracic, you will have to add right up to 5, between 3 to 5. And lumbar will be almost corresponding to T10 to T12, and sacral will be corresponding to T12 to L1. So that will be there. This is peripheral nervous system. We are not going to talk regarding that. These are ascending tracts. This is what we call as conscious proprioceptive fine touch, trunk and limb. That is position, vibration, touch and joint sensation. So this is a posterior column. And you can see this is how the posterior column will ascend. So it will ascend on the same side right up to the midbrain, medulla, where it will end in nucleus cuneatus and gracilis. Then the fiber will cross to the opposite side and then it will ascend up. It will combine with medial lemniscus and end in thalamus, ventro-posterior lateral nucleus of thalamus, and from there you will get a third order neuron and they will go via thalamocortical tracts passing through posterior limb of internal capsule and ends in cerebral cortex, we call it the post-central gyrus area of parietal lobe. So that is dorsal column, or we call posterior column, or we call fasciculus cuneatus or fasciculus gracilis, or also there is another name, tract of Gold and Berda, or we call tract of gracilis and cuneatus. As far as pain and temperature is concerned, we call it a lateral spinothalamic tract. So those particular fiber first ascend few segments on the same side, and then after ending in the posterior horn, that is tract of Liz, then fiber crosses just in front of central canal to the opposite side, and they divide into two, anterior spinothalamic and lateral spinothalamic. So both after crossing they ascend up. Anterior spinothalamic ascends in the anterior white column and lateral spinothalamic in a lateral column, and they will ascend right up to what we call as, it will end in thalamus, but in the upper part, that is in the upper part of midbrain. It will combine with medial lemniscus to become a spinal lemniscus. And then after ending in a VPL nucleus, that is ventro-posterolateral nucleus of thalamus, third order neuron will start, which will pass through the posterior limb of internal capsule and via thalamocortical tract, it will end in a post-central gyrus of parietal lobe. This will carry pain, temperature and light touch to opposite side of cerebral cortex, that is spinothalamic tract. Now this is fiber from the head and face, that is pain, temperature and simple touch, that is by a trigeminal nerve. So fiber coming from those three roots of trigeminal, that is ophthalmic, maxillary and mandibular. Then all those fiber will end in trigeminal nucleus in a pons, and from that the fiber will descend down few segments and then it will cross to the opposite side. After crossing to the opposite side, it will form trigeminal lemniscus, which will combine with spinal lemniscus and medial fasciculus, and it will end in ventro-posterolateral nucleus, ventro-posterior-medial nucleus of thalamus, and then third order neuron will pass via posterior limb of internal capsule and will end on cerebral cortex, post-central gyrus of parietal lobe, but close to the lateral sulcus, which is a part of face and neck. So that will be the area where it will end, and this will be to the opposite side of cerebral cortex. This is the sensation from neck and face from opposite side to opposite side cerebral cortex. Unconscious sensation from lower part of the body will be carried by posterior spinal cerebellar and anterior spinocerebellar, and it will end in cerebellum via inferior cerebellar peduncle. We are not going to deal in detail regarding this, so I am skipping that particular part. As far as the etiology of spinal cord damage is concerned, we have got infective pathophysiology like viral, bacterial, tubercular, as well as we call tabes dorsalis or we call neurosyphilis. Inflammatory pathophysiology, mainly which will be involving the peripheral nerves rather than spinal cord, that we call as a acute inflammatory demyelinating polyneuropathy, we short form call as a GBS. We'll have a traumatic injury in the form of a stab wound injury, bullet injury, whiplash injury, or because of fracture of vertebra, etc., or even a penetrating injury. Then vascular pathophysiology like anterior spinal artery syndromes or posterior spinal artery syndrome. Among tumor, it can be benign, it can be malignancy involving spinal cord, or there can be secondary metastasis. So benign tumor most common is neurofibroma. Among malignancy, gliomas, and secondary metastasis can be from prostate, breast, etc. Bronchogenic carcinoma, all those can have a secondary metastasis in the bone, that is vertebra. Also, you can have a demyelinating disease like multiple sclerosis or disseminated sclerosis. As well as the vertebra can be involved by tuberculosis, we call as a pot spine, and it can give rise to a tubercular involvement of the spine and vertebra can collapse, or you can have a cold abscess which is producing extradural compression or extramedullary compression. Degenerative disease like motor neuron disease, which can involve anterior horn cell, can involve corticospinal tract, and can also involve cerebral cortex. At present, we are going to deal with spinal cord, so it can be one of the presentation in case of a motor neuron disease. Or you can have a nutritional deficiency disorders like B12 deficiency, and one of the condition of B12 deficiency can involve posterior column as well as corticospinal tract. We call as a subacute combined degeneration. Toxins of kesari dal we call letharism, which is still quite common because good number of people consumes kesari dal in a food. You can have a cord compression secondary due to most common cause of cord compression is a prolapse intervertebral disc, which is usually lateral or we call as a posterolateral. And you can have multiple different types of presentation in the prolapse intervertebral disc. You can have a secondary metastasis, you can have abscess, you can have a hematomas, etc., which can produce a cord compression. It can be partial or it can be complete. So as far as the vertebral column, vertebral bodies are concerned, trauma producing fracture or collapse, disc lesion like prolapse intervertebral disc, or tumor which can be primary like multiple myeloma, and secondary metastasis from breast, thyroid, prostate, or bronchogenic carcinoma. You can have also involvement of the vertebral bodies by tuberculosis we call as a Pott's spine. You can have a involvement of meninges producing epidural abscess. You can have a tumor of meninges like meningioma or maybe related to the spinal roots like neurofibroma. You can have a infiltration by lymphomas, leukemias, etc. And tuberculosis can also involve meninges producing tubercular arachnoiditis. All this can produce damage to spinal cord. Spinal cord itself can be involved in developmental defect like syringomyelia, which will be a central canal lesion. There is a gradual dilatation of central canal. You can have a congenital defect like meningomyelocele or tethered cord syndromes, spina bifida, etc. Degenerative disorders like motor neuron disease. Then we can have certain other disease like Friedreich's ataxia, subacute combined degeneration, then hereditary spinal involvement, demyelinating disease or inflammatory disease like transverse myelitis, multiple sclerosis, neuromyelitis optica. We already mentioned previously that bacterial infection like tuberculosis, syphilis can also involve spinal cord. Viral infections like poliomyelitis, which will involve mainly anterior horn cell. And you can have a transverse myelitis secondary due to Epstein-Barr virus, HIV, herpes simplex virus, varicella virus, and even parasite can also involve like toxoplasmosis or schistosomiasis. Deficiency, we have already mentioned B12 deficiency, vitamin E deficiency, copper deficiency, and toxins, which is called BOAA in case of letharism. Vascular can be secondary to vasculitis like in case of SLE, periarteritis nodosa, those groups. You can have involvement of anterior spinal artery leading to anterior spinal artery syndromes producing infarction, or you can have a hemorrhage, you can have a AV malformation which can also involve spinal cord. Certain physical agents like radiation, lightning injury, etc. can also involve spinal cord, and very odd conditions like paraneoplastic syndromes can also involve spinal cord. So there is a big groups of disorders which can involve spinal cord. So we divide spinal cord lesion into different groups, and those are even given a name, spinal cord syndromes. So involvement of the spinal cord will be spinal cord lesion, or we call spinal cord syndromes, which can be complete or incomplete, or we call partial. Complete lesions can be acute, or we call sudden onset or abrupt onset. By and large, incompletes or partial are usually gradual onset or slow onset, or we call chronic. Good number of time compressive pathophysiology are usually gradual or slow onset or chronic. Very rarely compressive pathophysiology will produce acute onset and complete. By and large, compressive will start as a partial, slow onset, gradual onset, or we call chronic onset, and they are usually incomplete or partial. And in a late stage, they will be complete. By and large, good number of time non-compressive pathophysiology, which will be maybe infective pathophysiology, metabolic disorders, genetic disorders, etc., will be non-compressive pathophysiology, which can produce incomplete or partial damage. Very rarely they will produce complete, like in case of transverse myelitis. Traumatic pathophysiology again can be complete or can be incomplete, complete transection or partial damage. Another group, non-traumatic groups, can be incomplete or can be complete. Now, this particular will be using two groups, complete and incomplete. Now, among incomplete, we can come across what we call as a complete hemisection, we call as a Brown-Séquard syndrome. You can have only involvement of the posterior cord. Classical example is tabes dorsalis. Another example is subacute combined degeneration. But in a subacute combined degeneration, along with the posterior column, you have got involvement of what we call as a corticospinal tract. So we have got sensory plus motor involvement. While in case of a tabes dorsalis, mainly it is involvement of the posterior column more as compared to other parts. But you can have involvement of other portion of the spinal cord even in case of a tabes dorsalis. In case of anterior cord syndrome, the most common cause is an anterior spinal artery thrombosis or hemorrhage, which will have involvement of the anterior horns and anterior column and part of the lateral column, because anterior 2/3 of the spinal cord will be involved. So it will be a peculiar presentation in that group. Then central cord lesions, there are two common causes, syringomyelia and another is gliomas. Syringomyelia will be a gradual expansion of a central canal, which is very common in a cervical portion, and very frequently it will first give rise to lateral spinothalamic tract bilateral involvement because they cross just in front of the central canal, and then later on it can give rise to what we call as a quadriplegia, where it will be enlarged part of the central cord lesion, which is more commonly seen with gliomas rather than syringomyelia. Expanded central canal syndrome. You can have involvement of the lower end of the spinal cord, we call as a conal medullary syndrome, which can be involvement of all the other etiology we have mentioned, traumatic, non-traumatic, compressive, non-compressive variety, partial, complete, etc. all permutation combination. You can have involvement below the L1 level where spinal roots will be involved. We'll call that as a cauda equina lesion. So this will be again mainly lower motor neuron, while in a case of a conus medullaris, you can have upper motor neuron with lower motor neuron combinations. Also, you can get involvement which can be incomplete or partial in case of multiple sclerosis or disseminated sclerosis. Subacute combined degeneration, we have already mentioned classical example in a posterior cord syndrome. Latherism will be mainly involvement of the anterior horn cells. Again, it will be partial. You can have involvement at the uppermost part of the spinal cord, we call it close to the foramen magnum, we call it a foramen magnum syndrome. Very commonly because of the atlantoaxial joint dislocation, and it is very dangerous because you get also simultaneously damage to lower part of the medulla where cardiorespiratory center is involved, and person can have cardiorespiratory complications. You can have a complete transection. Poliomyelitis will involve mainly anterior horn cell only. So it will be only partial, it will be asymmetrical. Amyotrophic lateral sclerosis among motor neuron disease will be involvement in multiple portion. Very frequently it is involvement in the cervical cord lesion, where you will have involvement of the anterior horn cell producing lower motor neuron type of palsy in lower limb, and at cervical cord area corticospinal tracts are being involved, which will produce upper motor neuron variety in upper limb. Sorry, it will be other way around. So upper motor neuron in lower limb and anterior horn cell involvement will produce lower motor neuron in upper limb. GBS is mainly involvement of the peripheral nerves, mainly. That's why it is also called acute infective demyelinating polyneuropathy, but mimics identical like complete lower motor neuron type of palsy involving spinal cord. But you have to remember that it will be mainly involvement of the peripheral nerve. Syringomyelia, we already told you it is a central canal lesion, so it produces central canal cord syndromes, which will be involving mainly bilateral spinothalamic tract will be damaged, as it is very common in cervical cord portion. So it produces loss of pain and temperature in upper limb as well as the part of the chest. So that is a peculiar distribution of loss of sensation while preservation of posterior column, that is vibration, kinesthetic sensation or proprioceptive sensation and crude touch are preserved. Infection can produce partial or complete transverse myelitis, particularly viral. Traumatic injury like penetrating injury, bullet injury, step bone injury or fracture vertebra or collapse vertebra can also produce partial to complete transection. Tumors, very frequently tumors will be producing compression from outside. That will be extramedullary tumors. So initially there will be always partial, then it can produce hemisection, and then in a late stage complete transection. It will be always gradual or slow onset, or we call as a chronic, producing gradual compressions, and that is most common in case of a tumor. Very rarely we have gotten intramedullary tumors which will be expanding from the spinal cord and then producing the damage like gliomas. Anterior spinal artery syndrome will produce anterior 2/3 of the spinal cord damage because it supplies anterior 2/3 of the spinal cord, and that will produce anterior cord syndrome. We have got compressive pathophysiology, which can be because of tumor, can be because of hematoma, can be epidural abscess, can be because of pot spine, or can be because of neurofibromas, etc. And that can be partial or complete. And by and large, it will be usually gradual. Very rarely, compressive pathophysiology will produce acute compression and produces complete transection. So damage to the spinal cord will produce damage to the reflex arc, hence sensory and deep tendon reflex at the level of damage will be absent. Ascending tracts below the level of the damage, depending upon the area of damage, you will have a loss of sensation. And as far as the descending tracts are concerned, below the level, you will have an upper motor neuron because of damage to corticospinal tract, and at the level, you will have a damage to anterior horn cells and fiber coming out from anterior horn cell. So that will produce lower motor neuron type of damage. At the same time, there are fibers which are coming out from lateral horn cells like sympathetic fiber or parasympathetic fiber. So because of damage to those, you can have involvement of bladder and bowel, etc. Now, depending upon the type of a damage, whether partial or complete transection, whether it is acute or chronic, and where is the damage, the symptoms and signs of spinal cord injury will be present. But during damage, you get two types of presentation because of an acute damage to spinal cord injury, like acute traumatic injury or acute inflammation. You will have a stage of spinal shock, which will produce all voluntary reflexes will be below the level of injury, will be absent. So there will be decreased reflexes, complete loss of sensation, and flaccid paralysis. After few times, you will have complete recovery. Now you below the level, you will have a spastic involvement, but all sensation will be lost. And this particular spinal shock can last for days, very rarely 2 months, but by and large it is transient. Spinal shock and neurogenic shock can be there in the same patient, but not the same disorders. So what happens in a neurogenic shock? Because of the vasomotor involvement, there is a loss of vasomotor tone, loss of sympathetic tone, hence person will develop hypotension and bradycardia. And also person can have poikilothermia, that is unable to regulate the temperature in the affected part. This will be very, very peculiar, and this will happen within 30 minutes of cord injury. If it is below T5 or above, so if you have got a damage above T5 or at T5, you will have neurogenic shock findings, which will be very common. So do remember this, and this will be again lasting for a short period, and you might require some time airway support, IV fluids, atropine for treatment of bradycardia, and you might require a vasopressor for blood pressure elevation. But this is again temporary. So you have to remember that in a spinal cord shock, we get two types of shock, that is spinal shock and neurogenic shock. You can have both together or you can have only spinal shock, but neurogenic shock will be because of loss of vasomotor tone and loss of sympathetic tone. So those two will be producing all symptoms and signs, that is hemodynamic signs like hypotension, bradycardia, and unable to regulate the temperature. And person will also, if it persists for a longer period, you will require airway supports, fluid balance, atropine, and vasopressor drugs. So in a spinal shock, you do develop a hypotension and bradycardia because of neurogenic shock simultaneously. But because of spinal shock, you will have a loss of power, loss of sensation below the damage, and complete loss of reflexes below the level of injury. Bulbocavernous reflex will be absent. Bladder and bowel will be also involved in the form of incontinence, which will not be seen in a case of a neurogenic shock. You will have a flaccid paralysis, which is usually not seen in a neurogenic shock. You do get a flaccidity, but not flaccid paralysis type. By and large, it lasts for 48 to 72 hours after spinal cord injury. So spinal shock will be by and large within short period, may last for 48 to 72 hours after spinal cord injury. And mechanism here is peripheral neuron becomes temporarily unresponsive, while here autonomic pathway is affected. So there is a loss of autonomic control, that is sympathetic tone and vasomotor tone. So you get vasodilatation and you got loss of sympathetic tone which will produce hypotension and bradycardia. So that will be the thing as far as those two is. So whenever you get a spinal cord disease, you will have acute, you will have a flaccid. If there is a chronic spinal cord damage, it will be spastic variety. As far as the sensory is concerned, spinothalamic tract below the level, if only spinothalamic is involved, like in case of a Brown-Sequard syndrome, it will be the loss of pain and temperature on contralateral side and posterior column ipsilateral side. So this will be the peculiar presentation as far as sensory loss is concerned. And if it is complete transection, all the sensation below the level will be lost. As far as autonomic system is concerned, in acute, you will have a retention and flaccid, while in case of a chronic, you will have automatic bladder and spastic variety. This is very, very peculiar. So bladder in case of a recovery stage, usually it is an automatic bladder or we call spastic bladder. While during acute stage, it is flaccid and we have got retention of urine. Sometimes we also get urinary incontinence also. As far as deep tendon reflex is concerned, we'll have loss of all reflexes in an acute stage. In a chronic, deep tendon reflex will be exaggerated or brisk and we can get clonus. And as far as superficial reflex is concerned, during acute stage, all superficial reflex are lost. But in a recovery stage or in a chronic stage, abdominal cremastic reflex will be absent. But plantar reflex will be extensor or we call Babinski. There will be never altered level of consciousness. Cognitive function will be preserved. Cranial nerves will not be involved. If you have got altered level of consciousness, disorientation, cranial nerves involved, it has to be intracranial pathophysiology, not extracranial pathophysiology. And we will have two groups of findings as far as involvement of motor system is concerned. We get upper motor neuron finding if we get involvement of corticospinal tracts. It will be ipsilateral. Sorry. It will be ipsilateral. And usually in case of chronic or in a recovery stage, person will have a weakness, spastic, increased tone, deep tendon reflex will be exaggerated, clonus may be present, disuse atrophy in a very late stage, and plantar reflex will be extensor, no fasciculation. And in case of an acute damage, initially it will be a flaccid paralysis. All reflexes will be absent, including superficial reflex as well as a deep tendon reflex. Motor power will be zero, tone will be zero, you will have a flaccid. And once the person recovers, this will be the typical finding. While if there is a damage to anterior horn cell, then we will have weakness, flaccid, almost decreased tone or zero tone, no clonus, deep tendon reflex will be diminished or absent, you will have a atrophy, you will have a fasciculation, and you will have a plantar reflex downgoing or normal, and if there is a damage at the level of alpha S1, it will be absent. So we put them into two big groups, spastic paraplegia and flaccid paraplegia if there is a complete transection. So if there is a spastic paraplegia, muscle atrophy is absent, and if at all if it is there, in a late stage. While in a flaccid, atrophy and fasciculation will be very early and prominent. Muscle tone in spastic will be hypertonic, while in flaccid it will be hypotonic. Power will be partially diminished, while in a flaccid it will be total loss. Deep tendon reflex will be exaggerated in spastic and there may be clonus. While in case of a flaccid, deep tendon reflex is absent, clonus is also absent. Plantar reflex will be extensor, while in a flaccid, plantar reflex will be flexor or may be absent if there is a damage at the level of alpha S1. Now there is something called as a paraplegia in extension, paraplegia in flexion. We'll be also talking about this in chapter of paraplegia. This will happen if there is a complete transection above L1 level. As far as the vertebral level is concerned, it will be above T12 level. So, paraplegia in extension will be because of pyramidal lesion, while paraplegia in flexion will be because of pyramidal plus extrapyramidal system. In extension, there will be more tone in extensor group of muscle, while in paraplegia and flexion, it will be more in case of a flexor group of muscle. Lower limb will be extended, while here in paraplegia and flexion, it will be flexed. Deep tendon reflex will be exaggerated, or we call brisk, while in paraplegia and flexion, they will be less exaggerated. Clonus will be usually present in extension, while in case of a paraplegia and flexion, clonus will be usually absent. Now, most important part which will be there, which will be helping you to further differentiate extension from flexion, is a mass reflex. Mass reflex will be present only in case of a paraplegia in flexion, but mass reflex will be absent in case of paraplegia in extension. You will have in paraplegia and flexion, you will have automatic bladder, while here in paraplegia in extension, you will have precipitancy. That will be very peculiar in case of paraplegia in extension and paraplegia in flexion. You have to differentiate. So we have mentioned all those things. So following a complete transection of spinal cord, you will get paraplegia in flexion. This is following an incomplete transection, you will have a paraplegia in extension. So complete transection will usually produce flexion, while partial will produce in extension. Muscle tone reappears in flexor group of muscle because of reticulospinal tracts, while in case of a partial damage, muscle tone reappears in extensor first because of intact vestibulospinal tracts. And that's why in a partial damage, you will have increased tone in extensor group of muscles. Flexor reflexes are first to return. That is, plantar response will be responding first, while here extensor reflex will return first. That is cross extensor reflexes, and that will be in case of an paraplegia in extension, which is an incomplete lesion. Paraplegia in flexion occurs late, while this will be in an early stage being a partial lesion. And in a complete lesion, you will get paraplegia in flexion. This will be more common if you have got a higher lesion, while this paraplegia in extension is more common with a lower lesion. So this will be additional difference between paraplegia in flexion and paraplegia in extension. Complete transection will be more common with trauma, infarction, transverse myelitis, abscess, tumor, etc. And in a complete transection, we will have a complete loss of motor and sensory function below the level, and at the level, you will have lower motor neuron as far as motor is concerned and complete sensory loss. And below the level, in a case of a complete transection, as far as motor system is concerned, it will be upper motor neuron finding and complete sensory loss. In a hemisection, we get a typical, we call as a Brown-Séquard syndrome. I've already uploaded one in Brown-Séquard syndrome. You can go through at your leisure time. It is more common with trauma like step bone injury, penetrating injury, in multiple sclerosis, sometime in case of tumor or in case of an abscess where there is a partial compressions. Where on a ipsilateral side, you will have a loss of motor on the side of the damage, below the level upper motor neuron, and on the same side of the damage, you will have a posterior column gone, and contralateral side, you will have a pain and temperature gone. So that will be very peculiar. In a central canal damage, very commonly it is in case of a syringomyelia, or in case of a hyperextension we call as a whiplash injury, where you got a bilateral loss of pain and temperature. So motor impairment can be there, greater in the upper limb than lower limb, and you might have involvement of even bladder, because bladder center is very close to the central canal. So that will be in case of a central canal damage. As far as the anterior cord damage is concerned, which will be very peculiar in case of hyperflexion, disc protrusion, and anterior spinal artery involvement. And that will involve mainly motor system more involved, and may also involve lateral spinothalamic tract, producing temperature loss. Proprioceptive, that is posterior column, is always spared, and that is very, very characteristic in case of a anterior spinal artery occlusion. Cauda equina and conus medullaris lesion will be discussing separately, but just cauda equina very common because of PID, that is prolapse intervertebral disc, or maybe because of tumor, or maybe because of compressive pathophysiology or infective pathophysiology, where bladder and bowel will be more involved. You will have an altered sensation in a saddle area, and you will also have sexual dysfunction. This will be very peculiar in case of a cauda equina lesions. This is a slight difference between extramedullary, which you can divide into extradural and intradural, and intramedullary. Onset is always rapid in case of an extramedullary, while it is gradual in case of an intradural, and in intramedullary by and large it is slow as compared to rapid onset. In extramedullary, spinal tenderness is almost always present, while in case of an extramedullary but intradural, it is rare and it is always absent in case of an intramedullary. Root pain is the most common in case of an extradural, while in case of an intradural it is less common. It is always absent in intramedullary. Hence, indirectly, if person comes with root pains with spinal cord involvement, always suspect extramedullary compressions. Position of sense will be earlier loss because of extradural compressions, while in case of intradural also you can have a position sense lost, while intramedullary always, in all we say by and large it is always spared. Pain and temperature may be affected in all the three conditions depending upon the amount of damage. But in case of an extradural and intradural, which are extramedullary, as far as pain and temperature is concerned, it will be always first involvement of the sacral fiber, last involvement will be of chest and upper limb. While in case of an intramedullary lesion, it will be more of bilateral lesions, more common bilateral lesions, and more common in upper limb, we call jacket type of lesions. It will be bilateral pain and temperature loss. It is more common with the intramedullary. Classical example of that is syringomyelia. So as far as the sacral is concerned, it is quite early in extradural as well as in intradural variety, while there will be always sacral sparing in case of an intramedullary. Bladder and bowel involvement will be much more earlier in case of an intramedullary. So it is an early involvement because bladder center is very close to the central canal, while usually it is late in case of an extradural or intradural. So this is a simple difference which will help you to also identify spinal cord syndromes. So we have already mentioned in extramedullary, upper motor neuron signs will be more common because of involvement of the corticospinal tract, while in intramedullary it is usually late. Lower motor neuron findings will be mainly one or two segments at the site of the root compression in extramedullary, while you will have an involvement of the anterior horn cell, and it will be a little bigger area of involvement in case of an intramedullary lesions. As far as sensory system is concerned, root pain will be more common with extramedullary, while here it will be mainly funicular pains, that is we call in a posterior column, or we call typical funicular pains. Dissociated sensory loss will be very common in intramedullary, while in case of an extramedullary it is usually absent, meaning we will have also compression of posterior column as well as lateral spinothalamic. Both can be compressed. Sacral sensation will be preserved more in case of an intramedullary, and there will be early involvement in case of an extramedullary. Joint sensation will be also lost early in case of an extramedullary, while in an intramedullary they are usually late. Lhermitte's signs will be present in case of an extramedullary, while it will be absent in case of an intramedullary. As far as the bladder and bowel involvement is concerned, they are very early involvement in case of an early, while it is a late involvement in a case of a extramedullary. In case of an intradural and extradural, as far as the intradural is concerned, it is asymmetrical, acute and rapid, because it is very frequently because of secondary metastasis. While extradural is usually symmetrical, slow and progressive, because they are usually benign lesions. Vertebral body will be showing you less pain and gibbous, while extradural will be producing more pain and there will be gibbous. And whenever in an intradural variety, if it is a malignant involvement, then you can have back pain or vertebral pains. Same thing, whatever we have mentioned before, same thing is mentioned. At your leisure time, you can go through radicular pain, funicular pain, vertebral pain, upper motor neuron, lower motor neuron signs, sphincter, trophic changes, dissociated sensory loss, sacral sensation will be spared in case of intramedullary. They will be first involved in case of extramedullary. All those we have discussed. So autonomic system involvement will be there if there is an involvement above T5 level, and that can be involvement of bladder and bowel as well as skin involvement regarding vasoconstriction or vasodilatations. So bladder and bowel involvement will be very common. We'll be discussing in detail in case of a paraplegia. We have already discussed in a chapter of neurogenic bladder. So in an upper motor neuron lesion, we'll have a spastic bladder, or we call automatic bladder. While in case of a lower motor neuron, we'll have a flaccid bladder, or we call as an autonomous bladder. So we have discussed in detail in that. We have already mentioned in a cauda equina lesion, you will have a asymmetrical involvement, you will have a low motor neuron involvement, and you will have a root pains. That will be more common. So this is a little difference between conus and cauda. Conus is usually sudden or bilateral, while in case of a cauda, it is usually gradual and unilateral. That's why we always say asymmetrical, while conus is good number of times symmetrical. Pain will be more common with cauda because it is a root involvement, so person gets a radicular pain or root pains. While in case of conus, usually root pain is less common. Location of pain, it is symmetrical and in a perianal region and maybe along the thigh, while this is asymmetrical, maybe in the back, maybe in the leg, in the thigh or perineal region. Motor system wise involvement will be symmetrical, will be, if at all if it occurs, less, as compared to in cauda equina it will be low motor neuron and asymmetrical. Reflexes wise in a conus, because it is concerned with L2, L3, L4, so ankle jerk, good number of time it is absent. While in case of a conus, cauda, depending upon the involvement, you can have a ankle as well as knee being absent. Sensory level wise, saddle distribution will be more common with conus because it will be lumbosacral portion. So S3, S4, S5 will be more common involvement along with conus, and it will be symmetrical. While here in a cauda, saddle involvement will be there, but it will be asymmetrical. It will be one side more involved as compared to other side. Bladder and bowel involvement will be more predominant and early, while in case of a cauda, it will be less and in a late stage. Sexual dysfunction will be again very common in case of a conus. So indirectly bladder bowel involvement with sexual involvement with spinal cord findings will be more in favor of conus rather than cauda equina lesion. And another difference, important difference, in conus it is bilateral symmetrical good number of time and sudden onset, while in case of cauda it is usually asymmetrical and unilateral involvement and by and large gradual involvement. So if you remember these particular things, it will be very easy to identify conus and cauda. Conus will be little involvement close to T12 L1 level, while cauda equina will be below L1 level damage. Same, so we have told you conus medullaris L1, L2, this is below L2 level, cauda equina. All other majority of the thing we have already mentioned. So ankle jerk will be more affected in conus, while ankle and knee may be affected depending upon where is the damage or what will be the damage. Low back pain is more common with conus, it is less common with cauda. Sensory, we have already told you, it will be symmetrical and bilateral findings, while this will be asymmetrical and unilateral finding. We have already mentioned sphincter disturbances will be early and more common with conus, and it will be lower motor neuron finding like incontinence, while in a cauda it will be asymmetrical and late. So then if at all if it is present, it will be late. Impotence will be more common, it will be less common with cauda equina. So these are some of the differences which will be very important to differentiate between conus and cauda equina. What can selectively affect the epicaretic sensation or proportion, out of proportion to epicaretic sensation? You have to think it over, and that will be more common with we call as other lesion rather than spinal cord lesions. So Horner syndrome will be more common with lateral medullary syndrome rather than other groups. So it will be common with lateral medullary syndromes, maybe along with syringomyelia, which extends upward. I'll skip this particular slide. In a spinal cord damage, higher function will be normal, cranial nerves will be normal. Motor system at the level of damage on the same side, lower motor neuron. In case of hemisection at the level of damage, on opposite side it will be normal. Below the level on the same side, upper motor neuron type of findings. Below the level on the opposite side, in case of a hemisection, it will be normal. In a case of a transection at the level, both side lower motor neuron. Below the level on both the side, it will be upper motor neuron in case of a transection. Reflexes in lower motor neuron variety, it will be absent. In upper motor neuron variety type of damage, it will be brisk and clonus will be present. Plantar reflex below the level will be extensor. And if there is a damage at the level of alpha S1, plantar reflex will be absent. Bladder and bowel involvement will be there if the lesion is above T10 level, and it will be upper motor neuron variety. And if you have got a damage at the level of S2, S3, S4 spinal cord segment, like in case of a conus medullaris or in case of a cauda equina lesion, it will be a lower motor neuron type of a bladder and bowel involvement. Sensory finding wise, it becomes a very useful. Above the level, all sensation will be normal. At the level, there will be total loss of sensation, so we get sensory level. And below the level, in case of a transection on the side of the damage, complete loss of sensation, and below the level also complete loss of sensation. But in case of a hemisection on the side of the damage, loss of touch, vibration and proprioceptive sensation we call as the posterior column loss, and on the opposite side pain and temperature loss. This will be very useful to locate the site of damage, and this is very important. You can see the complete loss of sensation on both the side, equal loss, so it has to be a complete transection. Here partial loss on one side, partial loss of other sensation on other side. This will be classical in case of a Brown-Sequard syndromes. We call as a hemisection of thoracic cord. This is a loss of sensation only in a portion where upper part is spared, lower part is spared. This will be in a central canal lesion, particularly pain and temperature loss. So it will be syringomyelia suspended pattern, it is called, and it will be loss of pain and temperature. Sacral sparing will be very peculiar if it is an advanced intramedullary lesion. And here you can see that it will be anterior spinal artery, complete anterior 2/3 gone. This is sacral involvement will be more common in case of a cauda equina lesion, while this is a root distribution loss. So this will be because of radiculopathy, and this is glove and stocking type. So this will be because of involvement of peripheral nerve, we call as a peripheral neuropathy. So sensory finding may help you a lot to rule out this condition from spinal cord lesion like radiculopathy, peripheral neuropathy and cauda equina lesion. You can rule out very easily, and this will help you to identify where is the damage in case of a spinal cord damage. In complete spinal cord lesion, we have already mentioned classical example will be transverse myelitis, hemorrhage, penetrating injury, tumor, acute cord compression, traumatic injury, etc., in which below the level you will have a total flaccidity, all sensation loss, and if this lesion is at the level of cervical cord, that is C3, C4, you will have even phrenic nerve involved, you will have a respiratory involvement, you will have a urinary and bladder incontinence, that is bladder incontinence and urinary incontinence if there is a complete transection, and also bowel incontinence. And you can also have a finding in an acute stage, that is we call as a spinal shock findings, which person will recover then in a late stage or in a recovery stage. Person will have a spastic if the lesion is at the cervical above C5, you will have spastic quadriplegia, and if you have got a lesion after T1, then you will have a spastic paraplegia. In a central cord lesion, we have already mentioned, you will have a damage to spinothalamic tract which are crossing just in front of central canal. So classical distribution will be there, loss of pain and temperature in this area, sparing posterior column. So posterior column will be spared while pain and temperature will be lost. That will be characteristic. So in a central canal lesion or central cord lesion, you will have a loss of sensation in upper extremity. This is very common, where pain and temperature will be lost and preservation of position and vibration will be there because posterior column is not affected, and this is called jacket sensory loss. So typical sensory loss, that is loss of pain and temperature and preservation of posterior column. So that is very peculiar in case of a central canal lesion, and as the bladder center is very close to central canal, you can have a bladder involvement along with this particular if it is involving in the spinal cord. and particularly if it is involving the lower part. So on the opposite side, loss of pain and temperature, and on the ipsilateral side, because of damage to anterior horn cell, you will have lower motor neuron findings. If there is a damage to corticospinal tract, you will have hyperreflexia, spasticity, and plantar extensor. And if there is complete, this is regarding a complete Brown-Séquard syndrome. Sorry, this is central canal. Now this is a Brown-Séquard syndrome. So this is a Brown-Séquard syndrome, or we call hemisection. In a hemisection, opposite half of the body, below the level of damage, you will have temperature sensation, pain and temperature gone on opposite side, and on the same side, we call vibration, position sense, perception, 2-point discrimination, etc. lost. And because of involvement of the corticospinal tract, below the level of damage, you will have a increased tone, hyperreflexia, spasticity, and plantar reflex will be extensor. And at the level of damage, you will have loss of tone, weakness, atrophy, and even fasciculation, and complete loss of sensation, segmental anesthesia. So that will be seen. Loss of sweating, caudal level of sensation if lesion is cervical, and you can have Horner syndrome because the what we call as sympathetic fiber are arising from cervical spinal cord segments, and then it is supplying the dilator pupillary fiber of same side. So Horner syndrome can be seen if there is a damage in cervical spinal cord because of involvement of the lateral horns. This will be very typical in case of a hemisection, or we call Brown-Séquard syndrome. So on the side of the damage, below the level, motor system, on the same side affected. So you will have below the level upper motor neuron, sensory, pain and temperature will be affected on opposite side. Touch will be affected on the same side, particularly touch and posterior column will be affected on the same side. And below the level, all reflexes will be brisk, plantar will be extensor. And on opposite side, everything will be normal except pain and temperature gone. While at the level, on the same side, lower motor neuron palsy and all sensory segmental anesthesia and segmental lower motor neuron damage, while on opposite side, everything will be normal. So this will be very peculiar, and little above the level of damage, you might have hyperesthesia because of irritation of those fibers. When central canal lesion enlarges, we call it a large central canal syndromes, large central cord syndrome, which will damage the lateral spinothalamic as well as anterior spinothalamic, and at the level you will have a lower motor neuron, and below the level because of the involvement of the corticospinal tract you will have an upper motor neuron. Such finding is more common with multiple sclerosis and astrocytomas, which are common, which can expand very much and can involve. And sparing of the posterior column will be quite common, where you will have a sacral sparing because sacral fibers are outermost fiber. So whenever you get a sacral sparing, it is a central cord lesion. And if you get an extensive lesion only sparing sacral, so that will be very peculiar in a large central cord syndrome. And at the level, you will have a low motor neuron because of involvement of the anterior horn, and you will have a below the level upper motor neuron because of involvement of corticospinal tract. So that will be very peculiar in case of a large central cord lesion. In anterior spinal artery, anterior 2/3 is being involved, meaning anterior horn cells, lateral spinothalamic, corticospinal tracts, etc. may be involved. So that will produce very peculiar anterior two-third is gone, and because anterior two-third is gone, you will have complete upper motor neuron palsy below the level, at the level lower motor neuron, dorsal column will be preserved, but lateral spinothalamic will be gone. So pain and temperature below the level complete loss, dorsal column preserved, at the level lower motor neuron, and below the level upper motor neuron findings. So complete motor paralysis, pain and temperature gone, position and vibration being preserved, posterior column being preserved, and it is quite associated with flexion injury. Sudden sharp flexion can produce anterior cord damage, which will be a traumatic damage, while anterior spinal artery, anterior two-third may be involved. So this will be very peculiar. As far as the posterior column is concerned, very common in tabes dorsalis, or we call neurosyphilis, where you will have a loss of position, vibration, sensation gone, sensory ataxia, rhombic sign will be positive, positive sync sign, and positive L hermetic sign. You can have a posterior lateral column disorders, particularly in case of a subacute combined degeneration, that is B12 deficiency, HIV infections, cervical spondylosis, etc., where you will have a paresthesia in the feet, loss of proprioceptive sensation and vibration sensation in lower limb more involved as compared to upper limb. Person will have a sensory ataxia, rhombic sign will be positive, and bladder may be involved. And once there is a corticospinal tract involvement, below the level of damage, you will have a spasticity, hyperreflexia, and bilaterally plantar reflex will be extensor. And that is seen very peculiar in case of a subacute combined degeneration. So in a subacute combined degeneration, you can have a dorsal column gone, spinocerebellar tract involved, corticospinal tract involved, and it is mainly involvement of the upper thoracic and lower cervical cord involvement, and that is a peculiar involvement in a case of a subacute combined degeneration. So below the level, spasticity, exaggerated reflexes, bilateral plantar reflex extensor, and you will have a loss of position and vibration, that is posterior column gone below the level of lesions, and upper motor neuron lesions will be bilateral in case of subacute combined degeneration. That will be very peculiar. In case of a tabes dorsalis, it is a slowly progressive degeneration, and it is mainly because of involvement of the posterior column. That's why it is called posterior funiculitis, and it is common with tertiary syphilis. So you have got dorsal column gone, and then you can have a lateral root and dorsal root also involved, along with posterior white column involvement, and that is quite common in case of a tabes dorsalis. So in a tabes dorsalis, you will have intermittent attacks of lightning pain because of involvement of the posterior root, pain-free interval between the attacks, loss of sensations, particularly posterior column is being involved, and because of involvement of the posterior nerve root, you can have even loss of complete sensation. There can be Charcot joints will be seen very frequently involving the foot as well as knee, quite common. You can have even anesthesia of a central part of the face, anesthesia at the upper part of the chest and inner border of the hand around the anus and over the legs can be seen in case of tabes dorsalis. Loss of deep sensation, superficial sensation, deep reflexes and superficial reflexes are also lost because of involvement of those roots, and voluntary movements will be also involved because of involvement of spinal cord. This will be very commonly involved in a posterior column syndrome, and one of the cause of posterior column syndrome is tabes dorsalis. And whenever you get a posterior column involved, rhombic sign will be positive. Person will be walking with a stamping gait, that is a broad base gait. He raises the legs very high and then he slops the feet on the ground. So that is called high steepage gait or stamping gait. That is very common in case of a dorsal column involvement, or we call posterior. We usually use the word posterior column syndromes. Now there is one particular disorders I will be interested in talking about it. We call motor neuron disease. This involves brain, brainstem as well as spinal cord. So just a little idea, that is, in case of a spinal cord, there is a disorder we call as a primary lateral sclerosis, which will be mainly lower motor neuron type, and it is 1% of the motor neuron disease groups. And you can get lower motor neuron variety of lesion in a spinal cord, we call as a progressive muscular atrophy, which is in short we call as a PMA, and primary lateral sclerosis is labeled as a PLS, which is the upper motor neuron variety, means involvement of the corticospinal tracts, while in a progressive motor atrophy it is the involvement of the anterior spinal horn nucleus. While brainstem and brain involvement is concerned, there are two common groups we call as a pseudobulbar palsy and progressive bulbar palsy. Whenever there is a lower motor neuron involvement, that is the involvement of the motor cranial nerve nucleus, we call as a progressive bulbar palsy. While involvement of the bilateral corticospinal tract, we call as the upper motor neuron variety or a pseudobulbar palsy. Now, if you got involvement of upper motor neuron as well as lower motor neuron, means involvement of the brainstem and involvement of the spinal cord, we label that as amyotrophic lateral sclerosis, which is accounting for mixed variety groups, which is almost 85% of the time. So it is the most common group in case of a motor neuron disease. So if you come across upper motor neuron with lower motor neuron involvement findings together in the same person in upper limb and lower limb involving spinal cord and brainstem, always suspect motor neuron disease. There is one another group of disorders we call as acute flaccid paralysis. We divide into two big groups, just giving you a little idea. Asymmetrical will be classical in case of poliomyelitis. So we'll have a one side more involved as compared to other sides. In a non-polio enterovirus, also it is asymmetrical. And sometime in a pseudoparalysis also it is asymmetrical. While in case of a symmetrical variety, GBS is mainly bilateral symmetrical rapidly progressive ascending variety. Anterior spinal cord compression will be again bilateral symmetrical. Transverse myelitis will be complete transection of a spinal cord, so it will be bilateral symmetrical. And botulism is also one of the variety which will be bilateral symmetrical, acute and flaccid variety. So keeping all this thing in mind, sometimes we see this particular group of disorders. So it will also help you to identify the etiology if you come across a flaccid paralysis involving spinal cord. So in an anterior horn cell syndrome, one classical example is poliomyelitis. And there is one variety we call as a spinal muscular atrophy, which will be involvement of the anterior horn cell syndrome, where we get weakness, atrophy and fasciculation, hypotonia, all the reflexes will be depressed or absent, and sensory system is spared. This is very peculiar in an anterior horn cell syndrome. And classical example of anterior horn cell syndrome is poliomyelitis. Another is in case of a motor neuron disease, particularly as a part of amyotrophic lateral sclerosis. Also you can come across in a case of a spinal muscular atrophy, which is a part of motor neuron disease. So poliomyelitis will involve an anterior horn cell, which is a flaccid paralysis. You get a muscular atrophy, fasciculation, or reflexia but asymmetrical. One part is more involved as compared to other part. So, and it is more frequently involving lower limb as compared to upper limb. And there is no sensory findings. So, acute flaccid, asymmetrical, atrophy, cramps, fasciculation. But sensory system will be normal and very peculiar. One limb will be more involved as compared to other limb. We already mentioned in amyotrophic lateral sclerosis, progressive spinal muscular atrophy will be mainly involving anterior horn, and in a primary lateral sclerosis, you will have a corticospinal tract involved, which will be involving upper motor neuron finding below the level of lesion, mainly in lower limbs, and there will be increased tone, increased reflexes, and in upper limb, you will have a flaccid paralysis because of involvement of the anterior horn cell. This is very characteristic in case of amyotrophic lateral sclerosis. In a progressive spinal atrophy, muscular atrophy, it will be mainly anterior horn cell involvement, while in a primary lateral sclerosis, it will be mainly corticospinal tract involvement, and it is more common in cervical segment. Hence, you will have to differentiate as amyotrophic lateral sclerosis after minimum period of 4 years. If you get upper motor neuron and lower motor neuron finding together, because you can have progressive spinal muscular atrophy, and in a late stage you will get primary lateral sclerosis finding together, and then you will label that as amyotrophic lateral sclerosis. Disseminated multiple sclerosis is because of a demyelination in brain as well as in spinal cord. It is a widespread dissemination. It is always after ruling out. It is following an autoimmune disorders. There is a genetic predisposition. So depending upon the variety, whether it is a relapsing and remitting variety, by and large it is what we call as progressive and relapsing variety. That is more common, and that will produce in between the two episodes the person will have a static. So do keep it in mind, after ruling out all the other conditions, we label that as disseminated multiple sclerosis. You should differentiate spinal cord, pure spinal cord involvement from other conditions. If there is involvement of the face sensory loss, complete hemisensory loss, it has to be above the spinal cord. If person is having hemiparesis with hemianesthesia, it has to be in internal capsule lesion. If person has got one side facial sensory loss with opposite side hemisensory loss, always think in terms of a midbrain lesion. So spinal cord lesion is very peculiar. Invariably you will have a back pain, tenderness, weakness and sensory loss in the below the level of lesion. You will have a mixed upper motor neuron as well as a lower motor neuron. Lower motor neuron at the level of damage and upper motor neuron below the level of damage. You will have a classical sensory level, and invariably you will have parasympathetic and sympathetic portion being involved. So you will have a sphincter disturbances in form of a bladder and bowel disturbances and sexual dysfunction. We have already mentioned all this. I have mentioned regarding amyotrophic lateral sclerosis and motor neuron disease. So if in a case of a spinal root involvement, you will have a radiating pain, and always you will have a lower motor neuron type of involvement as far as motor part is concerned, and you will have a sensory findings on the side of the damage and root distribution. And depending upon the root involved, you will have a loss of reflexes, whether it is a deep tendon reflex or superficial reflex. In peripheral nerve damage, it will be always lower motor neuron type of a motor and sensory abnormality, complete sensory loss. If it is bilateral, then glove and stocking type of lesions, and you will have a loss of reflexes depending upon which peripheral nerves are being involved. In neuromuscular junction, it will be bilateral. You will have a ptosis, diplopia, dysphagia, proximal limb more involved as compared to distal part, increase muscle weakness with exertion. So fatigability will increase with increased action and increased exertion. There will be sparing of sensory loss. So there is no sensory loss, and person recovers with rest and with drugs. In case of a muscle involvement, it is bilateral, proximal more than distal, and sparing sensation. And person will not recover with rest or with drugs. So this is a difference between myopathy and neuropathy. A simple difference: in neuropathy, it will be distal. In myopathy, it will be proximal. In neuropathy, deep tendon reflex will be absent, while in myopathy, they will be preserved. Sensory loss will be absent in case of myopathy, while they will be sensory loss invariably will be present if it is a sensory motor neuropathy. And this is the difference between myopathy, anterior horn cell disease, peripheral neuropathy, and myoneural junction. Almost we have discussed, so I am skipping this particular slide. And just to mention, in a myopathy, distribution wise proximal as compared to distal, it is symmetrical. Atrophy is early and marked in case of myopathy. Fasciculation will be absent. Reflexes will be lost in a late stage. Pain will be because of myositis. Cramps will be not common. Sensory loss is usually absent. And creatinine kinase, or we call CPK, will be usually elevated. In anterior horn cell disease, it will be usually distal lesion, asymmetrical, and marked in early stage. You will have atrophy. Fasciculation will be almost always present. Reflexes, depending upon the lesion, you will have reflexes will be almost absent. Because of anterior horn cell damage, it will be a lower motor neuron damage. Can be hyperreflexes, I don't agree. In an anterior horn cell, it will be along with corticospinal tract then only. Pain usually not affected. Cramps may be there. Sensory loss not present. Serum kinase occasionally, but maybe because of atrophy, may be slightly elevated. In peripheral neuropathy, it is distal and symmetrical. Atrophy usually in a late stage. Fasciculation may be seen. Reflexes will be lost in a late stage. In an early stage because of involvement of the motor fibers. Pain may be there. Cramps occasional. Sensory loss usually because of involvement of sensory fibers. CPK will be normal. Neuromuscular junction, almost we say that commonly you will have involvement of the extraocular muscles, upper eyelid muscles, proximal more involved as compared to distal, and you can have a bulbar muscle involvement. Atrophy will be absent, fasciculation will be absent, reflexes will be normal, pain will be absent, cramps will be absent, sensory loss will be absent, and CPK will be also normal. So if you keep this thing in mind, you will be able to differentiate between myopathy, anterior horn cell involvement, peripheral neuropathy, and neuromuscular junction. Because neuromuscular junction, peripheral neuropathy, and myopathy are outside the spinal cord. Only anterior horn cell will be spinal cord involvement. So to differentiate these three groups, you should be able to identify those three groups from spinal cord damage. So same thing is mentioned here: muscle, nerve, root, anterior horn cell, and spinal cord involvement. At your leisure time, you can go through. And again, peculiar, in all this lesion, that is spinal cord, root, nerves, muscle, or cord involvement, level of consciousness, speech, cortical sensation, and cranial nerves will be normal in all. Indirectly, if you get involvement of this, you have got damage above spinal cord. We already mentioned that weakness can be upper motor neuron variety, lower motor neuron variety, or myopathic. At your leisure time, you can go through. We have already discussed before. So I'm not repeating again. This is one slide which is showing you acute, subacute, and chronic involvement. Again, by and large, we have discussed majority. At your leisure time, you can go through these two slides. So you can go through that this as a leisure time. This you can go at leisure time. But depending upon the onset, acute, subacute, or chronic. In acute, you can have motor, sensory, mixed variety. In motor, upper motor neuron, lower motor neuron. In sensory, posterior column, spinothalamic. In mixed variety, what are the etiology? And this is in a subacute variety and chronic variety. In subacute, motor, sensory, and mixed, what are the conditions? So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. If you like this particular lecture, please don't forget to press button like and subscribe and press bell icon so that you get a notification for the second lecture. And if you feel that this is helpful to your friend, you can share with your friends. I feel this will be very helpful to you in your everyday practice, as well as good number of things can be asked to you in your oral and something can be always there in your theory exams. So see you in next lecture.